Good morning and welcome to Trauma Grand Rounds, sponsored by Northeast Georgia Medical Center. There is no commercial support for today's program. The planners have disclosed no relevant financial relationships with any commercial interests. Our speaker does have a few disclosures, and these have been mitigated prior to the activity. For successful completion of this activity, learners must attend the complete activity for CE credit with no partial credit available. If you have a question for our presenter, please hold until the Q&A segment at the end of the talk. If you're attending virtually, please enter that question into the Q&A section, and we'll make sure to ask that for you. A link to the event survey will be shared at the end of the program. It is my pleasure to introduce our guest speaker, Dr. Zach Balest. Dr. Balest received his medical degree from the Medical College of Georgia, University of Georgia Medical Partnership in 2014. He went on to complete his residency training in ophthalmology at Emory University in 2018 and is board certified in ophthalmology. He currently practices with North Georgia Eye Associates, serving patients across Gainesville, Toccoa, and Clayton, Georgia, as well as Murphy, North Carolina. Dr. Balest brings a comprehensive approach to the eye care and is dedicated to advancing clinical knowledge and patient outcomes through continued medical education. Please join me in welcoming Dr. Balest.
All right, good morning. Thank you all for having me. As she mentioned, I'm Zach Balest. I practice out of North Georgia Eye Associates here in Gainesville and kind of all over Northeast Georgia and into North Carolina as well. And we're going to, cram about a year's worth of knowledge from covering Grady eye emergencies into about an hour. So hold on to your seats here. She said hold the questions to the end. I don't know if that's an official thing that we have to do, but I'm here for you guys. I want to help you out and teach you what you feel like you need to know or help cover the common issues that you have to know. So I'm okay with you stopping me at any point if you have any questions. If that's not okay, then we can do that at the end. Just remember what the questions are and what you need from me, really. So, all right, we'll get started here. Financial disclosures, none of which are relevant to our talk today. We're going to jump right into this one. So we're going to cover kind of triaging eye conditions when they come in just a minute. But this one I wanted to hit right off the bat to kind of emphasize that this is something that we don't wait on. I don't want anybody in the room to be thinking whenever they see somebody coming in with a chemical burn, even if they've already been irrigated prior to arrival, irrigate these guys again. So these can turn really, really nasty in a hurry if they're not handled appropriately. And so the most important thing is just getting that eye rinsed thoroughly as soon as possible. So, saline is ideal, and we have different mechanisms for doing that. We have rinse bottles. We have the Morgan lens that you connect to the IV bag and put inside the eyelids. But really anything that you can get to, if the faucet is the only thing around, put those guys under the faucet and have, just as flushing it as much as you can. Once you've irrigated, then you really want to carefully inspect the eye. Most of these patients are going to have some conjunctival abrasions. They're going to have corneal abrasions, and we'll get to that later. But the main thing that you're really searching for is any particulate matter that can solidify whenever this goes on. So little nuggets can kind of hide way back in the fornix between the inside of the eyelid and where the conjunctiva folds over to come back over the surface of the globe. So you really want to avert the lids on these patients and again, rinse if you see anything, make sure everything has gotten out of there because those will continue to leach the chemical and cause further damage. Especially in the hospital, if you've got it available, pH strips are great to check that you've neutralized the pH on the eye, and if it's not, you just need to continue irrigating until that normalizes. And these patients need referral to an ophthalmologist for immediate follow-up. So this is something, we need to be coming into the hospital, or if there's not somebody available on call, these need to be transferred because, again, what you can see are in the acute phase, you get this conjunctival edema we call chemosis. You can get this injection. You can see how this light reflex is very irregular. That's a sign that the epithelium is not healthy and it's probably absent. So, these patients need antibiotic prophylaxis in the immediate term. But if they're not handled with steroids, or even if they are, sometimes you can get these really severe changes to the cornea, which you can imagine you can't see through that very well. So they get all this neovascularization and scarring of the cornea, which results in permanent vision loss. And this is not something that you can easily fix with a corneal transplant. With all those blood vessels growing in on this, it's highly likely to fail. And so this can be really, really devastating for a patient. All right, so now let's get into, how do we evaluate a patient when they come in with an eye complaint? So we call these the ophthalmology vital signs. So this is something that we try to check on every patient that comes in with some sort of eye injury or some sort of eye or vision complaint. So vision, pupils, pressure, motility, and their confrontational visual fields. Obviously in a trauma setting, sometimes these are not all, patient's not cooperative enough or you're just not able to check all of these things. But this is our goal to get this data. All right, so visual acuity. It sounds easy, check somebody's vision, but practically, how do you do that? So it's important to check one eye at a time. Obviously, if a patient has one eye that's affected and their other eye is perfectly normal, if you check with both eyes open, you're going to miss the issue. And in the hospital at the bedside, we don't need somebody sitting in a chair looking at a chart 20 feet away or through a mirror. And so we need gross estimates of vision. We don't need an exact number. So I get called all the time and says, well, the patient can't see out of that eye. There's, as you can imagine, a very wide range of vision that would fall into that category. You can have somebody that's normally 20/20 and they are missing one line because of something, and they're going to describe that as very blurry, and you've got people walking around that cannot see anything in front of them other than a hand moving, and they're just used to it and they wouldn't know any difference. So we need some sort of objective measure of that. So we all have name tags now. There's posters hanging in the room. See what the patient can read, see what it is compared to the eye that's affected and their unaffected eye, and compare those things. Apps on our cell phones now, we've got an eye chart available. You can download these for free. So there's lots of different ways to just get some sort of gross estimate of this. The other thing is I really care about what their vision is with their glasses. So I see a couple people with glasses in here today. If I take your glasses off and check your vision, how relative is that to what your vision should be? So, make sure that if they do have their glasses, which again, understandable in a trauma situation, they may not come in with their glasses, but again, a lot of times they know what their baseline is without their glasses, and they can give you some sort of estimate of where they should be. All right. Yes.
How does the phone app compare to the paper chart? Because that's
so
larger, not light, not lit.
Correct. So again, it's not an official measurement and nothing that we'd use for any sort of clinical trials or anything like that. But again, we're just really trying to get a gross estimate. The problem with the phone and a near card or your badge up close is that if your patient is in their mid-40s or later, they have a medical condition called presbyopia, where you can't see up close, which is where people need either readers or bifocals. So if they're checking the near, you need to make sure that that patient has that. You'd be amazed at how many people are walking around that way that don't really wear readers to begin with. So they're just going to have some trouble up close. But those, some of those are validated and compared, and we have some standard cards that you use at a standard distance in our clinics, but not necessarily, all the way correlated, I would say. All right. So pupils, what are we actually looking at with pupils? You look in every patient's chart under the neurologic exam, it says perla or pupils equal, but not a lot of people really know how to utilize this part of the exam. There can be some extremely useful information, and there can be some hints that something serious is really going on. So we'll go over a couple of different aspects of the pupil exam here, but this is not something to just ignore. This can really point you towards some key findings or key underlying issues going on. So what we're really looking for are the pupils round. The normal pupil should be round. If it's not, is this related to the trauma? Has the patient had some kind of prior surgery and their pupil is not normal from that? Intraocular inflammation, uveitis can cause the pupil to scar down and can cause it to be irregular. You're looking for anisocoria, so are pupils equal between the two eyes? If they're not, again, there's a large percentage of the population, probably 10%, that walks around with unequal pupils. Usually it's such a small difference that you don't notice it, but if you see something more significant going on, that can be a sign of some serious issues, some life-threatening issues. Do the pupils react to light? And we're talking about direct and consensual, which we'll cover in just a minute. And then really the biggest thing that I'm concerned about is looking for a relative afferent pupillary defect. So we've probably all heard that, or a Marcus Gunn pupil back on our board exams. But to actually check for that is really a little bit of a skill. It's not difficult, but just understanding what you're looking for is the key part there. And that can really tell you there are some things that cause severe vision loss. Then the eye may look perfectly normal. You know, we're talking about optic nerve injuries. You have traumatic optic neuropathy. They can come in with a retinal artery occlusion, and you will see this on these patients even though you may not see anything on exam. So really important finding, and we're going to really cover that. So, all right. Where are residents that we can pick on? I'm guessing it's this side of the room over here. Okay, so who wants to tell me what they see in this photo? Okay. All right. Which pupil is the abnormal one?
Can't tell without other information.
Okay.
But probably the right one because the light's shining in the face.
Yeah. Okay. So you're exactly right. You can't tell from the photo. So one, we need to measure that, and there's ways that we can do that, which get really more into kind of the complex and maybe more on the neurology side of things. I wouldn't really expect you guys to figure this out, but you want to look for other clues as well. And it's a little subtle in this picture, but if you look, this lid has a little bit of ptosis, so that's your clue that it's actually this side. 99.9% of the time, people didn't even they say what you do. They say this pupil is wrong because for whatever reason our brain, the bigger pupil is the abnormal one. So what you're looking for are some other clues when you see anisocoria. So ptosis on the side is going to kind of point to the side that is abnormal. So this patient actually has a Horner syndrome. And so you're looking for other clues like ptosis or any sort of motility deficits. All right, so this one's a little bit more obvious. They're obviously holding up the eyelid because of it. So this is a third nerve palsy. So a couple of things that you can see there are there was severe ptosis on that side, so much so that they had to lift the lid. The pupil is much larger on that side, and if you look, that thing's a little bit deviated off to the side, and the way that you can tell that, it's obvious, you can just see it, but if you look, that light reflex right there is not in the center of the pupil, it's more towards the nasal side. So in subtle differences, you can see that light reflex just not lining up in the middle on both sides. All right, so here's the kind of the key slide with the pupil side of things. So we're going to kind of walk through this slowly because, like I said, this is really important. So on the normal side, when you check pupils, what you want to do is first kind of shine the light. You want the lights down, and this is really important. Remember going into Grady as a resident, the brightest lights are everything. There's stuff thrown all over the room. They want to know if the patient has an orbital compartment syndrome, and the first thing I got to do is you've got to turn the lights off. You just cannot check pupils in a bright room and really expect a reliable response. So pupils off, and you want something really bright. And the first thing I do is I kind of get the light as dim as I can or indirectly shine it just so that I can see the pupils and make sure that they're equal. And then you want to assess each eye individually. So you're going to take your light and you're going to shine it at one eye, and you should see a constriction from kind of their normal resting state to a smaller size. And then you want to check the other side as well. And then you're going to do the swinging flashlight test where you go back and forth, so one eye to the other. And as you swing between the two eyes, you want to go pretty quickly, and even going quickly, what you'll see if you watch closely is that as you're between the eyes, the pupils are going to dilate just a little bit. Some patients it can be dramatic, some patients it can be really, really subtle. But as you swing from one eye to the other, what you're looking for is to see if one pupil either appears to dilate when the light hits it or does not constrict as much as the other side. So when we say direct and consensual response, when you shine a light in an eye in a normal patient, both eyes constrict. So your direct response is in the pupil you're shining the light in, the consensual response is the other side, and they should be equal. So in a patient, let's say the left eye here is the abnormal eye, and this patient's going to have a relative afferent pupillary defect on that side. So as you shine the light in the normal eye, both eyes constrict just like you would expect normally, but when you swing to the other side, it's going to appear that this pupil is dilating because the brain and the pathways in the back is not sensing as much of light coming in that side. And so again, you can go back and forth. If it's dramatic, it's easy to see. It can be really, really subtle, and I get called into my technician's room every day to check one of these, and I'm saying, I'm not really sure, maybe. And so then you really kind of rely on our diagnostic exam and testing afterwards. But again, really important finding. If you see this, something is going on, and it's usually something serious, either serious from an ophthalmic standpoint or serious from a neurologic standpoint. So let's see if I can get this to pull up here. All right, so this is just a website that shows this rather than just having a figure. So again, normal response, both eyes, you swing across, they're both coming down equally. This patient has a relative afferent pupillary defect in the left eye. So when you go from here to here, see how that pupil's getting bigger? And you're looking for consistent finding. It's not uncommon for patients' pupils to kind of bounce a little bit as you're doing pupil testing. And after you do it for a few seconds, you probably need to stop and give them a break and let everything reset. But this is what you're looking for. So right eye to left, that pupil is just getting larger. When it's severe, it can be really dramatic. So there's essentially no response when you swing over on an eye that has a really severe one. Okay, anybody have any questions about that part? Okay, good. All right, so next is pressure. Gold standard pressure measurement is what we do in clinic with what's called a Goldman tonometer. It requires a slit lamp. You have to put fluorescein on the eye, topical anesthesia, patient cooperation. That's obviously not what we're doing here. So thankfully we have some devices that can help us out. The most common ones that we see in the hospital are called Tonopens, which are these two down here at the bottom. We've got one up here. We can play with this later and walk you through things if we want to get hands-on, if you have questions about how to actually use it. But when you're using these, there's a little cover that you put on the tip. The problem that I see 9 times out of 10 when people are not able to use these is that it's not calibrated. So they do have to be calibrated pretty frequently. It's actually a very easy process to do that, and you can quickly look up a YouTube video or something, and you can do it in about 15 seconds. So there's just a specific, push the button, it has to be turned a certain way and held and then turned again. So really easy to do, but those are great. A newer device that we have now is called the iCare. These are even easier to use. These are really awesome. This is what we use in our clinic because they're really efficient. The problem with those is that there's a little tip that has to go into this part right here, and it works by rebound. So you push the button and it shoots this little probe out and it actually touches the cornea. You don't even have to anesthetize the eye. It's so mild that patients really barely feel it. But the problem is that in trauma situations you won't be able to use that because the probe will fall out if you have to turn it. If they're in a supine position, the patient has to be mostly upright in order to be able to use that. But hoping that they can maybe come out with a model at some point that you'd be able to use where you don't have to keep it upright. Let's see. All right, so when we're checking pressure, again, this is meant to be really practical. How do you actually check pressure? It's easy to say, hey, go check the pressure, but how do you actually do it? So when do we not want to check the pressure? If you're worried about an open globe, don't touch the eyeball. That's kind of the best thing. Any little bit of pressure can cause prolapse of intraocular tissue, make the patient's long-term prognosis much worse. So that's about the only time I don't want somebody touching pressures if you're really suspicious that there could be an open globe. Again, you want to make sure there's calibration. And the biggest thing that I see is, patients, obviously, they want to squeeze, they want to close their eye if you're coming at them with something. So you're going to put your numbing drops in first, Preparecaine, you can order that to the bedside, just put a drop or two in. But people want to really kind of pry their eyelids open, which is okay as long as you don't put any pressure on the eyeball. So opening these things up and pushing really firmly against the orbit is okay, but if you put any little bit of pressure on the actual eyeball, you're going to get some artificially elevated numbers. So, we get called a lot of times pressures, in the high 30s, but really it's not because, I'll have them recheck it and just make sure you don't put any pressure on the eye and it'll be normal a lot of the time. Okay, normal ranges, 10 to 22. A patient running, even 30 for a few months is not a big deal. What we're looking for is significantly high pressures in the setting of some other issue going on as well. So you'd be surprised. You got people with glaucoma that are walking around with pressures in the 40 that have no idea. They don't feel anything. So kind of take it in context. And then again, if you don't have one of these available, palpation is fine. So you can test against your own eye. If you close your eyes, you take your 2 index fingers and kind of blotch your eye between your 2 fingers. You can get an idea. Your eye feels about like a grape, maybe a little bit less firm than that. And you can compare to the patient's other eye as well. So if a patient's, in angle closure and that's what you're worried about, they've got a really red, hot eye and it's all of a sudden out of nowhere, their pupil's fixed and dilated, palpate that eye and it'll feel like a marble if they are. I mean, it gets really firm. And again, you can always compare to yourself or to the other eye. All right, visual fields, probably invoking some PTSD here, looking at that. This is favorite board question, and this is not really. This is lowest on the list of the ophthalmology vital signs for me. This is not something that we're looking for more neurologic issues when we're doing this, but we're going to do it to be thorough. So one eye at a time. Make sure the patient covers up their good eye, or the eye that you're not testing. Everybody cheats whenever you do this. As soon as you put some fingers out to the side, they're going to look over there. So you may have to repeat it multiple times. You want to make sure you get on the same level, so you're eye to eye the patient. Get down in the chair, whatever you need to. And I close my eye about halfway between myself and my patient. I try to just get a couple feet away. I start bringing in my fingers, and you can check for movement, or you can actually ask them to read your fingers. And you're comparing against yourself. So assuming that you have normal peripheral vision, right when you're getting to the edge of your visual field is where they should start being able to see something. So if a patient comes in, they've had some sort of trauma, they're complaining that their vision's blurry off to the side, they've had some flashes and floaters, you're concerned about a retinal detachment. Again, you want to check every quadrant, and this can be somewhat useful in that situation. If you catch a defect that's new and they have these other symptoms, that's something that the patient needs to get checked out for. All right, and then motility. So checking motility, everybody goes up, down, left, right, but that's not that useful. You'll find some abnormalities, but that doesn't help you localize the problem. So because of the anatomy of the orbit, the orbit's situated a little bit temporally versus the kind of plane when you're checking the patient looking straight ahead. And because of that offset, if you have a patient that's in primary gaze, means looking straight ahead, and you have them look up or down, they have multiple vertical muscles that are acting at the same time. So that doesn't isolate you to a muscle or a specific cranial nerve. So in order to check it and isolate these things, this is kind of the pattern that we want. So horizontal muscles are easy. If it's looking to the side, then it's lateral rectus. If they're looking in, it's medial rectus. But vertical muscles, what we want is to have them look to the side, and this is going to align their eye with the orbit so that you only have either the superior and inferior rectus looking. So if I look to my right, if I'm looking up, that right eye is superior rectus. If I'm looking down, it's inferior rectus. In that same gaze, different muscles are acting on my left eye. And it's flipped, so your superior rectus is actually causing the eye to go down, and your inferior oblique and superior oblique, are causing the opposite. So again, just aligning things with that orbit allow you to isolate the actual muscle and isolate the cranial nerves that you're looking at. Okay, basic eye anatomy is really important. So I would tell you, probably 7-8 times out of 10 when somebody calls me and tells me, the eye is red, you have to really specifically, is there blood inside of the eye? Is the blood over the white part of the eye? Any sort of basic anatomy that you can use to help describe things really helps us to triage the patients. And so things that are important, your cornea is this front clear window on the eye. You should be able to see straight through that. If something's going on that's causing it to be cloudy, it's very noticeable. If it's not, then you don't really see it when you look at somebody's eye. The anterior chamber is the area between the posterior cornea and the iris here, and so that's where we see blood with hyphema. We have something called a hypopyon where there's a lot of inflammatory cells floating around that will settle out. You'll see that there. Also assessing the depth of the anterior chamber. If you really get down and you shine a light from the side, you can see if there's that normal space there. If a patient has angle closure, or if they have an open globe and their anterior chamber is collapsed, that's something that you can see, and that there's no depth to the anterior chamber. The iris is the colored part of the eye, the blue or the brown part of the eye, and the pupil is the central opening of that. The natural lens is behind that. When that lens gets cloudy, that's called a cataract, and we've got some slides later on that. Conjunctiva, it starts at what's called the limbus, which is the junction between the cornea and the sclera, and it goes all the way back into the fornix, and it rolls over, and it comes back and lines the inside of the eyelid. So sclera is the white part of the eye. The conjunctiva overlies that. That's really one of the big things that I see, is that people can't identify what's the sclera versus what's in the anterior chamber. And then obviously we've got our structures in the back, which you're not going to see without some sort of diagnostic equipment or special equipment. So external view here. So again, you got your eyelids. Sclera is the white part. Iris right here. Pupils in the center. Those are kind of the basic terms that we need to know when we're trying to describe where a problem is. Okay, so we'll jump into some more cases here. All right, so another resident want to take what they see here? Anybody? Okay, so redness, edema, swelling of that eyelid. So we say this is an 11-year-old boy. This kind of just came up a couple of days ago, has been worsening, no real history there. So this is preseptal cellulitis, and we're going to contrast this to postseptal or orbital cellulitis. Extremely important to distinguish the two. They're managed dramatically in different ways. So preseptal cellulitis or periorbital cellulitis, they present with tenderness, redness, warmth, swelling of the eyelid. And again, it's important to distinguish between the two, and how do we do that? So just to kind of get into the actual difference between the two, the orbital septum is this tissue that divides basically the anterior eyelid from the posterior orbital structures. So you got your skin and your muscles and your soft tissue anterior to that. Posterior to that is where your orbital fat, extraocular muscles, and optic nerve are in the orbit. And so if the inflammation and infection is isolated to the anterior tissues, that's preseptal. Obviously, if it goes behind that, that's postseptal. Preseptal is managed, you typically as an outpatient with oral antibiotics, and usually responds pretty well. It's usually associated, and kids for whatever reason tend to have this a lot more than adults. Orbital cellulitis is vision threatening and can be life threatening. So if this is going on, these patients are admitted to the hospital, they're getting IV antibiotics, they're getting checked on every single day. What you're looking for, what are the keys to distinguishing this? And so I've got a couple of slides on this. So proptosis, if the eye is actually starting to bulge some, and we call these orbital signs. So that means something's going on back in the orbit. If the patient is having, I'm not sure what happened there. If the patient is noticing pain whenever they're moving their eye, so pain with movement, or if they're having restricted movement and they can't look up or down or left or right, those are more signs that something's starting to go on in there. You can get preseptal cellulitis with a lot of conjunctivitis at the same time. And if that happens, they may have blurry vision, but kind of take it in context. If the eye is really kind of a little red and injected and they've got a bunch of mucus, that's probably why their vision is blurry. But again, you just got to be on guard with these. Double vision, you can have normal motility and have based off your exam, it can look very normal. But if they're reporting double vision while this is going on, that's another very concerning finding that something's going on there. So these patients, they don't have proptosis, they don't have a relative afferent pupillary defect, they don't have any restriction or pain with motility and no decreased vision, and usually the conjunctiva is not that inflamed. Again, so this is not a big ordeal, but this is. So this is orbital cellulitis. So this patient has, a lot more severe edema. If you look here carefully, you can see this redness of the conjunctiva. We describe that as injection. It just means the blood vessels are really distended there, and you can see that the chemosis is kind of the swelling. You see this on your ICU patients. They're getting a lot of fluids, and that clear tissue just starts hanging over. That's chemosis. And again, when you're checking their motility, you can see this eye's going up and this one's not going anywhere. So those are what you're really concerned for. And again, checking for an APD. If you see an APD in a patient that's got this going on, this is orbital cellulitis, this is trouble. And really, we're going to get a CT scan on these patients to figure this out. Other findings, fever, leukocytosis, those are the other big things that you're looking for. Yes?
Is there a different cause for each of them? A reason for that?
The preseptal stuff usually comes from something anterior, a break in the skin or something like that. And like I said, kids just get this sometimes for some reason, the preseptal side. Orbital cellulitis is almost always associated with sinus issues. So they almost always have chronic sinusitis. There's another condition that is very similar to this. It looks exactly the same. It's called orbital pseudotumor. They come in with this red hot eye. They've got orbital signs. You scan those patients and their sinuses are completely clean. And they're actually managed with steroids. So first 24 hours, you're kind of really nervous about, is this an infection? Is this orbital pseudotumor? So you've got to watch this carefully. But sinus disease is the answer to your question. All right, so here's a CT scan. This one's not too crazy, but what you're looking for is signs of inflammation in the orbit. So a lot of times these will have a subperiosteal abscess. If they have that, then that needs to be drained, typically by oculoplastic specialists. You can see proptosis going on, stretching of the optic nerve out. But these are this is a radiologic diagnosis a lot of the times. So again, hospitalization, IV antibiotics, they need an ophthalmology consult. Blood cultures are drawn. If there is significant sinus disease or there's subperiosteal abscess, then ENT gets involved, or oculoplastics. And then these patients can also get meningitis as well, so neurosurgery may need to be involved if that's going on. All right, again, we monitor these patients really, really closely because this can be a blinding condition. All right, so this is probably something you guys see every day. So these are corneal abrasions. This is a patient that doesn't have fluorescein on the eye. So as you can see, this is really dramatic and easy to see, but a lot of times it can be really subtle. So there's this big epithelial defect in this area. This is how you see these easily, is with a fluorescein exam. So I've got a Woods lamp up here. These are available in the hospital, but honestly what I like is one of these. So I bought this thing off of Residency for like $5. So cobalt blue light in your pocket. You can also have an app on your phone that will shine a blue light. It doesn't work quite as well, but these things are like $5. And so this works just as well. The Woods lamp is nice because you get some magnification, but you've got to plug it in. You've got to go find that thing. These are awesome. I mean, you can put some fluorescein on the eye and you can see an abrasion. If somebody, like I've got a friend that calls me on the weekend, they come by the house, this is what I'm using. Like, this is so easy. So what you see is this fluorescein will actually stain the area of the cornea where there isn't an epithelial defect. It jumps out at you. It's easy to see. So patients usually are really uncomfortable with these. You know, sharp pain, feels like something's in their eye. They're tearing. They can't even open their eye. The lights are driving them crazy, blurred vision, and there's typically some kind of history of trauma. And again, you diagnose this with the fluorescein and the blue light. So again, how do we do this? So easy to do at the bedside. Everybody in this room can do this. Order some proparacaine to the bedside, put a drop in the eye. There are fluorescein strips, so you order these in Epic. They will deliver that with your proparacaine to the bedside. You open this up, hold it by the white part, take a drop of the proparacaine or even just saline from a syringe, and you want to just put a couple of drops on this part. Pull the patient's eyelid down and kind of tap that orange part on the inside of their eyelid, have them blink a few times, and pull your blue light out and look at it. And that's it. It's simple, and you will see it there. The trouble becomes distinguishing a corneal abrasion from a mild ulcer, which we'll get into a little bit. So treatment for these, broad spectrum antibiotics to prevent a bacterial infection. The go-to is just moxifloxacin, and we order it usually about 4 times a day. And it's absolutely necessary if the patient has a history of contact lenses. So those patients are super high risk for Pseudomonas infections, so you've got to have some Pseudomonas coverage. Moxifloxacin is the best one and readily available. If a patient doesn't have contact lens wear and they're allergic to fluoroquinolones, or for some reason they can't get that, Polytrim is another good option. Antibiotic ointment is great. Giving them erythromycin ointment can help with the discomfort. So you imagine you've got this open wound on your cornea. Every time you blink and it rubs past there, it's really uncomfortable, and it can take longer to heal because you're kind of debriding that area every time you blink. So antibiotic ointment provides this barrier and usually will make the patients a lot happier. The big thing you want to do is you want to avoid any topical anesthetics. There's one, imagine if you're sitting there with this excruciating eye pain and you've got this magic bottle that's going to numb your eye up, and it works for 10 minutes. Every 10 minutes you're going to put that in your eye, and that can cause some really, really serious issues. And so, don't leave the bottle in the room whenever you do this. Take that thing with you because the patients will use it, and they can get themselves into some big trouble with that. All right, so this is a corneal ulcer. Again, kind of so we can walk through and help how you describe things whenever you're calling an ophthalmologist to consult on a patient. So there's conjunctival injection. There is a mottled or irregular light reflex, and then what we also see is this discrete opacity in the cornea. And then this is a hypopyon down here. So if you tell me, you see this opacity on the cornea, the conjunctiva is really red, and I see a hypopyon, I'm getting out of bed like I need to know about this. Versus, hey, I've got this patient with a red eye. Obviously, very different stories, and that means a lot of difference to me. So this is a corneal ulcer. This needs to be seen by an ophthalmologist. Obviously, this is much more dramatic. This is a much more severe cornea. So, the cornea is basically almost totally opacified in this instance. Again, you've got this chemosis and injection of the conjunctiva, and it's a large opacity of the cornea. Here's another. I would say this is kind of a moderate corneal ulcer. So, again, injection of the conjunctiva, corneal opacity. irregular light reflex. All right, frequently due to mechanical trauma, or the other number one risk factor for these things is sleeping in your contact lenses. So you've got to discontinue the contact lens wear during the infection. Patients sometimes hate that. Sometimes they don't have a backup pair of glasses, and they can have really poor vision without their contacts, but it's a must. You cannot be in a contact lens during this. Early detection, again, is extremely vital. The sooner that we can get on top of these things, the more that we can help these heal and reduce scarring and permanent vision loss. Aggressive antibiotic drops or antimicrobials. These can be bacterial, they can be viral, fungal, parasitic. You can't tell by just looking at them. We've got to go a lot of times just based off kind of the mechanism of what's going on in the history and then how they respond to our treatments. We do like to culture these a lot of times, and that will help as well. Okay, does anybody know what that is? Pretty textbook finding. Yes, so this is a corneal dendrite. So again, it kind of jumps out at you. Not all patients that have herpetic eye disease actually have a dendrite, but that's a classic finding. If you see this is herpetic, this patient needs Valtrex. So these can actually be quite subtle as far as symptoms go. So these patients can be like, I just have a little bit of irritation, or sometimes they actually have some anesthesia, some deficits there, and so they may not be real uncomfortable at all. So if you see that, though, that's definitely herpetic disease, and they need antivirals. They can be associated with skin vesicles. This can be either HSV or VZV. If a patient comes in with zoster and you see any staining on there, then the good news is they're already going to be on an antiviral, and that's the treatment. There are topical antivirals, but their dosing is either 5 times a day or 9 times a day, and they can be toxic to the cornea. So it almost depends on where you train what you use. But oral antivirals, unless it's a young patient with a central defect, then I'm just doing orals. The topicals can be really expensive as well. And the key here is that you got to avoid steroids. Steroids can make this problem much, much worse. So no steroids in these patients. And my opinion is, unless you're an eye doctor, you really should not be prescribing topical steroids, because it's too difficult to tell exactly what's going on sometimes, and they can get you into some big trouble. All right, corneal foreign bodies, these are also extremely common. This is the patient that comes in at Friday. They say, well, on Tuesday I got something on my eye, but it didn't really bother me. They do okay, actually. Maybe feel a little something. They're usually not that painful to begin with, but then you get this inflammatory response, and they get this photophobia, and they come in and they're just screaming at 5 o'clock on a Friday that something's going on here. So little metallic structure there and there. And like I said, a lot of times they're just complaining of just a little bit of a foreign body sensation. The key to these things, you need to make sure this is not full thickness. And so these can be removed pretty easily at the bedside. I like to take just a cotton tip applicator, soak it in Prepare-K, make sure you put some drops on the eye first, and you can just kind of sweep that area. You want to really stay where the foreign body is. You don't want to get around larger than that, because you're going to create a big abrasion when you do that, and it's going to take them longer to heal and feel comfortable. So don't go digging too hard. If it doesn't just kind of sweep right off, then give us a call. But a lot of these, you'd be surprised, you can just kind of flick them off with just a cotton tip. Before and after removing these things, I would recommend that you do a fluorescein exam, because these things can be full thickness. And what you're looking for is called the Seidel sign. So you put the fluorescein on, and if there is a full thickness wound and it's leaking, you'll see the aqueous kind of coming out, and it creates this stream, and it'll flush the fluorescein away. And so you want to make sure that, one, there's not one there beforehand, and if you do remove the foreign body, that it wasn't full thickness and kind of plugging that wound. Obviously, these need to be repaired. All right, and if these are either seen in the hospital and sent to us, or they're removed in the hospital, they need an antibiotic prophylaxis until everything's kind of healed up. All right, conjunctival lacerations. These are also extremely common. The biggest thing here is you need to make sure that there's not something underlying this as well. So, conjunctival lacerations, they're usually uncomfortable, but they're usually not, just dying like a corneal abrasion. But you can do the same thing. Take a cotton tip, soak it in Prepare-K, and you can kind of move that conjunctiva around. Obviously, if there's suspicion for an open globe, then don't do that, because again, you can kind of push intraocular contents out and make things worse. But you can manipulate that just a little bit. A lot of times these things are going to have a subconjunctival hemorrhage, and it's going to be hard to see. So that's the kind of the tough thing about these. But if you've got something that looks like that, it's pretty easy to just move that conj around a little bit, make sure there's nothing going on underneath there. And you're going to base a lot of that on the symptoms. If somebody has a scleral laceration, they usually have really bad vision because they're either going to get a vitreous hemorrhage or they're going to have a retinal detachment. Those are usually a little bit more obvious. If these are small, less than about a centimeter, we don't repair them. They'll heal up just fine. If they're larger than that, then we'll put a couple of sutures in. And erythromycin ointment is just more for comfort and kind of help them heal with that. Sometimes you can see some foreign bodies underneath there, and if there are, again, you can kind of pull those out with the cotton tip. But key is just making sure there's no underlying scleral injury. So hyphemas are also extremely common. Patients present with pain, blurred vision, history of trauma. There's the blood visible in the anterior chamber. It usually starts to kind of settle down. It can completely fill up the anterior chamber, and that's a lot more severe condition, but most of the time they're a millimeter or two down at the bottom of the eye. Keeping the patients upright will cause those to settle out of the visual axis, improve their vision. So that's kind of part of the management of these patients. But the big thing is to kind of determine the mechanism. So a lot of times these patients need a CT scan if there was some sort of projectile injury to make sure there's not something actually in the eye. It's a good idea to measure pressure. You got to be really careful with these eyes. They can rebleed, which makes the situation a lot worse. So you don't want to be putting a lot of pressure on the eyeball, which you shouldn't be doing again when you're checking pressure anyways. But their pressure is really important in these. Some people can have really sky-high pressure, and especially in patients that are at risk for sickle cell, you want to check for that. They're managed completely different. So if I get a hyphema, it's not going to be a major deal as long as things are resolving and the pressure's okay. But you've got to watch the pressure in a patient with sickle cell like every single day when they have this, because those can go downhill in a hurry. We put these patients essentially on bed rest for the most part. No real activity. They can, if a patient has a mild one, they can go to the bathroom and eat, but really textbook on these is pretty much bed rest, just again because of the risk of rebleeding. Again, elevating the head, having them sleep up, propped up on a couple of pillows over the bed, elevated, helps that blood to settle. We want to shield the eye pretty much at all the times so that they don't reach up and rub it or something like that and cause a rebleed. We typically like these patients to be dilated with cyclopentolate or atropine. They get put on a steroid drop and then any drops for pressure control if needed. And then again, we try to avoid any unnecessary blood thinners just to decrease the risk of rebleeding. All right, let's see. Orbital fractures. So you can see this kid here, that eye's pretty quiet, right? So not real injected. There's not a whole lot of swelling or anything like that, but that eye is not going up like it should. And this is what you'd see on a CT scan, a little trapdoor fracture. The inferior rectus is trapped there. This is what we call a wide-eyed blowout fracture. These kids get fixed right away because this muscle is going to fibrose and they're going to have permanent motility deficit. So this doesn't look very impressive, but in a kid with any sort of entrapment like that, then they're going to get fixed. Versus somebody with a huge defect like this, that entire orbital floor is missing. I'm a lot less concerned about that happening in those. These can be delayed a lot of times. The other thing that you look for, and this will come into play later when we talk about orbital compartment syndromes, when you have large fractures like these and you've got a retrobulbar hemorrhage, it's actually kind of a good thing because that gives an area for all this hemorrhage to escape and so that the pressure doesn't build up in the orbital compartment. So that's something that I'm looking at in those cases as well. So these are really common, right? Like you see these all the time. So what we're assessing for is there some sort of ocular involvement with this? Do they have any other sequelae from their trauma? So things that you want to look for: double vision, extremely common. Motility restriction is really common. So a lot of times we base whether these things need to be repaired or not off the imaging. So again, entrapment needs to be fixed pretty quickly. But if they're just really swollen, the guys really like to wait a week to 2 weeks before fixing these things, just because it makes the surgery easier once the swelling goes down. Ocular cardiac reflex is an indication for immediate repair. So if the patient, you're checking their motility and they start getting a little queasy, or they're hooked up to the monitor and their heart rate starts dropping, those patients need to be fixed right away because that can be life-threatening. Again, rule out an open globe. Make sure you're really carefully looking at the eye. Subconjunctival hemorrhages are extremely common. I'm not worried about that, but assessing that patient's vision and kind of doing our vital signs will help you really pull out if there's any suspicion for an open globe. Textbook with these things, as long as they don't have any new ocular complaints, then they need an exam within a few days to a week. There can be some incidental findings, so we like to just, if you get socked hard enough that it breaks your orbital wall, then it's a good idea to get your eye checked. And again, indication for repair, we talked about the immediate ones, delayed repair if they have persistent diplopia. If there's more than half of the orbital floor involved, we like to fix those because if not, down the road, that eye is going to kind of sink into that socket or into the sinus a little bit, or if there's other complex trauma involved. Okay, retrobulbar hemorrhage. So this is a really important one for this team. So this is a clinical and a radiographic finding or diagnosis. So this patient, again, has chemosis and some subconjunctival hemorrhage. These patients have proptosis and what we call tense lid edema. So you can see some really serious eyelid edema. But if you can kind of pull the lid back enough and you can move it and you can see this little, minute separation from the eyelid and the globe, that's okay. But what we call tense lid edema is it's so tight that you cannot separate the eyelid from the actual globe. And that is a much more concerning finding, that there's something posterior kind of pushing out against it, and those tendons in the eyelid are kind of holding it so it has nowhere to go. And that builds up intraocular pressure, it builds up intraorbital pressure. So again, you can see all this hyperdensity on the CT scan that's back in the orbit. You see this pretty significant proptosis on that side. And again, association with orbital fractures is usually a good thing because it's going to decrease your risk of orbital compartment syndrome. So these patients will have pain, decreased vision, proptosis, resistance to retropulsion. As long as you're sure there's not a globe or hyphema, then you can kind of push on that eye and see if it's really difficult to push that thing back. Again, the tense lid edema, elevated pressure. What you're looking for really though is elevated pressure and an RAPD. If you see an RAPD, that patient needs to be cut before you pick up the phone. It can take less than an hour to cause permanent vision loss. So this pressure builds up, it causes ischemia to the optic nerve, and that patient has forever lost their vision. So these are emergencies, just like we were talking about the chemical burns earlier. This is something that should be looked at, assessed, and taken care of before you ever call the ophthalmologist. So how do we treat this? This again can be a clinical diagnosis. A lot of times we don't really catch it until it comes up on the CT scan, and that's because they're not an orbital compartment syndrome. It's more just a retrobulbar hemorrhage. And then the question is, well, what's going on here? You have to watch those for any evolution to see if things are worsening. But this is a clinical diagnosis, and immediate canthotomy and cantholysis is the answer to this. So essentially what you're going to do is you're going to take some scissors and you're going to cut laterally right through the lateral canthus. It doesn't have to go far. You want to go down to about the orbital rim. And what you're wanting to do is loosen that enough that you can actually grab the lower eyelid and flip it out just a little bit. And when you do that, that lateral canthal tendon, so you've got a superior and an inferior that come together right here at the lateral orbital rim. And you want to take your scissors and kind of just strum that area. And you'll feel, it's pretty rigid structure. You'll feel that, like the soft tissue of the eyelid, you won't feel anything. But if you strum that, then you just cut. And you keep cutting until the eyelid is literally just kind of hanging down. If the eyelid is still opposed to the globe, you haven't cut the tendon. You've got to cut the tendon to really release the pressure. And it's good to verify that their pressure goes down after you do the cut. All right, traumatic optic neuropathy is something that we see, thankfully not that often. It's a diagnosis of exclusion. We got to make sure that there's nothing else going on. But you can have direct injury to the optic nerve, which you can see. These cases are obvious and easy to see. But a lot of times it can be to indirect injury. Actually, I saw a patient yesterday that had come through the hospital a few months ago, had a bike accident and fell with the helmet on and hit the front of her head, and that indirect impact, in this frontal area can cause these traumatic optic neuropathies. They can be mild or they can be really severe. The key is that you will see an RAPD in these patients. So they can have an entirely normal eye exam, and nerves look perfectly normal in the acute phase, but they've got an RAPD definitely if this is going on. All right, so I've got a couple of cases here. So this was an 87-year-old male who presented ground level fall, and first point of contact, he came into the ER right around 7 p.m. He had a CT of his face that was done. He had an orbital floor fracture. He had exophthalmos and a noted retrobulbar density concerning for retrobulbar hemorrhage on exam. So what's our next steps here? Again, we're going to kind of go back to our default, our ophthalmology vital signs. We're going to try to check the vision best that we can. pressure, motility, and you're really looking at those lids in that situation to assess for any orbital compartment syndrome. And really you'd like to have that before they go to CT scan again, because by the time they go and come back and you get your stuff together and you order that, they could have vision loss by that point. So, covered that part there. All right, so turns out this was actually an extended family member of mine, so I was not on call. I operate up in Murphy, so I was in bed pretty early, and my phone rang like 10 times in a row. So I'm like, what's going on? And so about 9:35, the daughter called me and said, hey, they're trying to transfer this patient to Grady. And it was because of this retrobulbar hemorrhage. They weren't comfortable with managing that. So I said, well, I'm in surgery tomorrow in North Carolina. I can have you seen first thing in the morning. You've got this big orbital fracture. It's very unlikely that you've got an orbital compartment syndrome. Let me call them and talk to them. So I called the ER up and spoke with the provider there. And at that time, 2.5 hours after presentation and hours after having the CT scan, they had not looked at vision, they had not looked at pressure, and they were essentially had already arranged for transportation. So you're talking about another 1.5 to 2 hours before they get to Grady, and then they're going to call an ophthalmologist to come in there too. And so I said, all right. I said, I think that we can handle this without the transfer. I can get them checked out first thing in the morning, but we need to make sure a couple of things are okay. So go check the pressure, call me back. Pressure turned out it was 48. The patient had an orbital compartment syndrome despite this big orbital fracture. And so I said, you've got to cut them right now. So got a canthotomy and cantholysis, and then they were actually transferred that night to Gwinnett Medical for whatever reason. But so again, really a delay of care there. This is not really defensible. If this went to litigation, this is something that would be settled. This is something that any emergency provider, trauma provider should be prepared to evaluate this and do this. So just to kind of point out that, the first thing when you see these things, you've got to look for this. So top of the list. All right, case 2. So this was a patient they called me about, 87-year-old female, had a ground level fall. She was saying that she had some blurry vision, but this lady had some mild dementia, and it was kind of hard to really determine much from her history, what was a little tangential, what was really going on versus not. She had this history of some eye issues. We didn't really know if this was her baseline or not, but trauma resident gave me a call and said, this lady's got a little bit of blurry vision, but he's like, the eye looks okay. He said, but her pupil is a little bit abnormal. So, all right, I'm coming in to see this patient, and he didn't know what he was seeing, but he knew something was wrong. So again, he kind of caught this by really paying attention to the eye. So if you look there's a subtle little irregularity to the pupil there. It's not nice and round. There's a subconjunctival hemorrhage and chemosis. And this patient had an open globe, so little tiny laceration at the limbus, and close enough that essentially as that fluid comes out, it drags some iris with it. And these can be pretty subtle, but he picked it up. Like I said, he didn't know exactly that it was an open globe, but he knew something was off. So again, paying close attention to the pupils can really help you out in these cases. So again, a little bit larger picture there. Again, irregular pupil. So open globes, you've got to maintain a high suspicion because sometimes they're obvious. You've got this huge area of iris that's coming out. Their pupils all distorted. The eyeball looks like a smushed grape. But sometimes you can have something really subtle. This eye is very white and quiet. The only thing that you see is that little bit of abnormal iris. This was a kid that I saw at CHOA when I was at Emory. He was in class and classmate threw a pencil at him. Pencil poked this tiny, tiny little defect in the cornea. He got transferred in from the outside because they didn't feel comfortable evaluating the eye. But I mean, that's very subtle there. You could easily overlook that. Things that are concerning for an open globe on your exam: severe subconjunctival hemorrhage. If it's 360 degrees and it's kind of bullous, we call that hemorrhagic suffusion. That's really suspicious that there's an open globe, and a lot of those we explore. Sometimes we don't find anything, but if there's really significant subconjunctival hemorrhage and it's 360, that's a little bit more concerning. A shallow anterior chamber, again, like we mentioned earlier. If they have a peaked or irregular pupil, and if that's associated with a hyphema, you've got blood in multiple layers, so hyphema and a subconjunctival hemorrhage, those are a little bit more concerning. So once suspected, don't touch the eye anymore, don't touch the eyelid. Get a shield or a cup, whatever you can find, tape it over it to protect that eye. You want to get a CT of the orbits to rule out any kind of intraocular foreign body. They're also helpful for us a lot of the times because you can see some abnormalities of the curvature of the globe. These patients get put on NPO, pain control, bed rest. They need IV antibiotics, tetanus updated, all those things. And either call us to come in and fix it, or if there's nobody on call, then obviously those get transferred. Just a couple of pictures here for common things. We'll run through these really quickly and we'll be done. Just some very common things that you can see just so you know what's okay and not something that's really concerning. So this area right here is just kind of hypertrophic or hyperkeratotic conjunctiva. It's called a pingueculum. They're extremely common. It looks a little bit yellowish or calcified on exam a lot of times. These are really common in people that spend a lot of time outside, in the sun or the wind. Nothing to be concerned about. Every now and then they'll get a little bit inflamed and they can be really red, but again, not concerning there. This is a pterygium. This is where the conjunctiva kind of crosses that barrier between the sclera and the cornea, and it grows across there. These are also extremely common. And then subconjunctival hemorrhage, mild one like this, extremely common. A lot of times in y'all's situation, they're a lot worse than that. You can have some really major subconjunctival hemorrhages. But again, blood underneath the conjunctiva on top of the sclera. And this is a picture of a cataract. This is a really severe cataract. Most of the time around here, we don't have these. I mean, I do one of these probably a couple of times a month, but most patients with a cataract, you won't have this significant of a finding, but the kind of thing I wanted to point out here is you can tell this because you get really clear iris details when you're looking at this patient. So the cataract is back behind the pupil, versus if you have this clouding and you can't see the iris details, that's more concerning that there's a corneal opacification, which is obviously going to be a little bit different management. All right, that's all I've got. So one thing Dr. Vassy and I were talking about, so again, I'm here to help you guys, and it seems like one of the main questions is, when do I need to transfer something versus when do I not? So hopefully being able to know how to assess the patients will kind of narrow that down, whether this is something that we're really concerned about and we need ophthalmology for. But are there conditions that y'all feel like you can run across commonly that maybe I didn't cover and that you would like a little bit more specific guidance on how to assess those and figure out whether they need to be transferred or not? When I was at Emory, our protocol typically was dilated eye exam within a week. That was kind of standard, and there's some papers to support that. In patients that don't have any specific ocular complaints. So if the patient adds on that they have really blurry vision or there's something more concerning going on, then those patients need to be checked out pretty much right away to make sure there's not some coexistent, retinal detachment or vitreous hemorrhage or something like that going on. So it's really going to be based off the history and gross eye exam. Obviously, we're not dilating a patient and doing a fundus exam unless we're coming in to do that, and we do that in the clinic. So a lot of times the patient comes in, it's an isolated trauma, an uncomplicated fracture. Unless there's concerning history or concerning finding on the CT scan, then outpatient follow-up is okay on those. If the patient's going to be admitted here for a little while and they're unstable and there's concerning finding, we come in to see that, or they have to be transferred. If they're stable, we've been having a lot of patients transferred to our clinic recently. The hospital's done really well about arranging transportation and sending inpatients over and sending them back. So that's always an option if the patient's stable. And we have pretty much somebody here every single day in Gainesville that can handle that and take a look at it. The other thing is that obviously we have some gaps in weeks that people are on call, but our office actually sees a ton of patients from the hospital, especially the ER, when there's nobody on call. So you can always call our office and say, hey, I've got this patient. Is there a doctor that I can run this by? And most of us are pretty open to having that discussion to tell you hey, yeah, this is concerning. I can see this, or no, we don't have anybody available that needs to be transferred, to just help you triage if there's a question. But again, the patient's going to tell you most of the time if there's something going on, and they do need to be seen quickly, but most of these are not an emergency. It's really the patients that have something on CT scan that's more concerning, a retrobulbar hemorrhage. Those I would recommend that they get seen a little bit sooner. Or the patient says, yeah, I've got really blurry vision on this eye, or I'm having a bunch of flashes or a bunch of new floaters. Those are the key things. This is one of the toner pins that I showed. The other one is just kind of a long stick, but essentially there's going to be a button on either one, and you push that to turn it on. It'll kind of run and kind of turn itself on, and it'll beep whenever it's ready. And so you're going to have one of these covers that you put on. Let's go ahead and do this. So take the cover, slide it on here. There's a little notch right there, and you unroll the cover until it hits on that notch, and then you take this off. So that's just for just protection of the patient, that you're not spreading any infections. So there is a flat surface right on the tip of this. And what you want to do is you want to hold this. If you need to hold the eyelid open, you do that. And you got to be careful with this because you can give a patient a corneal abrasion if you're not careful. And it does not take much pressure at all. So you want to kind of stabilize on something the best that you can. Hold the patient's eyelid up. And what you're going to do is you're literally going to just tap. I mean, gently tap like this. You're going to make sure it doesn't turn off because you take so long. But I mean, you're just tapping like this. And you want to do, each tap will give a little beep. I don't know if y'all can hear that or not. And do it a few times and it will pop up an average of those. Sometimes you'll get something that says an error. That means it was either tilted or it's giving really inconsistent measurements. But you can just reset and start over and do it again. And it'll give you a message there. The biggest thing is, like I said, if it has to be calibrated, it's a really quick process. Sometimes they've got an instruction card in the case, but again, you can find that on the internet really quickly. You don't want to hold it on the cornea. You don't want to move it around on the cornea. It's a tap. It's off, on, off, on, off, on, off, on, and just very gently. If you're doing it too soft, you won't hear the beep. So, don't be too cautious. You do have to do a little bit of a tap there, but it does not need to be forceful, and you don't want to move it around. You want to try to get as perpendicular to the front of the cornea as you can. If you're a little bit tilted like this, you're kind of getting on the edge of that flat surface, so you want that flat surface really kind of tapping the cornea. Yeah, so these, if the patient is down on the floor, I mean, you can do that. You want to be perpendicular to the cornea. Yeah. And it's exactly the same with the other model. They look a little bit different, but they work the same. Sometimes you have to pull the lids back off of the globe because there is such edema that it can cause those pressures to be falsely elevated. Sometimes doing that can actually make it worse by putting that pressure on there. When we have to do that, we either have specialized instruments or we'll actually take a paper clip and fold it so that you can put it underneath the eyelid and have somebody sit there. Like I've had, nurses in the ER help me hold those as I check a pressure. Probably not something I would recommend that y'all do just because of the risk of getting a corneal abrasion with that, but that's the workaround about that. It's a problem. I mean, the swelling can cause that. The Morgan lens can be uncomfortable because it goes underneath and kind of sits on the eyelid and it's rubbing it where it's inflamed. But usually the irrigation, you think about if you get anything in the eye, the first thing you want to do is rinse it out. They usually tolerate it pretty well. 99% of the chemical injuries that I see were irrigated on site. It's if somebody's working at home, and they've got some bleach flushed up in their eye, those are the ones that you got to worry about. And hopefully they ran to a sink or something and rinsed it out. But most of the ones that are on the job site now, thankfully, have been rinsed long before they got here. I like moxifloxacin a lot. It's a good one. Sometimes I do polytrim depending on if there's an allergy, but moxifloxacin is a really good broad spectrum medication for that, especially if there's, like I said, contact lens history, moxi.